very good evening to one and all. So for the next 1 to 1.5 hours, we're going to have a quick revision of high yield topics, right? But image-based questions that have been asked previously in your NEET PG entrance examination, right? So it's really going to be a very exciting, interesting session. And I want you people to make it more interactive. Okay. So we'll be like doing more of a MCQ type. Any idea like how many questions come from anatomy for your NEET PG entrance examination? You have your chat box, right? You can keep entering your answers there. How many questions do you expect from anatomy for your NEET PG or INI-CET? Yes, it can be as many as 12 to 16. Okay, so totally have 19 subjects to read from an anatomy like, yeah. So if you could make out like completely answer this 12 to 16 questions correctly, it is definitely going to boost your marks, isn't it? Yeah. So out of these 12 to 16 questions, more than 90%, okay, around 14 of them are going to be image-based questions, right? It can be an indirect one, but it's going to be image-based questions mostly. Okay. And weightage of questions. So I have mentioned here all the regions of anatomy. More questions every year they come from the topic of upper limb, followed by head and neck and neuroanatomy. And definitely there's going to be one question at least from embryology and histology. Okay. Also, we get questions from abdomen, lower limb, and thorax. So more weightage is always applied to upper limb, head and neck, neuroanatomy, histology, and embryology. Okay? Yes. The eye sees what the mind knows. So if you're really been preparing for NEET PG entrance examination, like first year MBBS, did you go through your whole anatomy textbooks? I'm sure you won't have the time for it. You'd have chosen like high yield topics, previous year questions, all that, right? So whatever topic you choose, make sure you learn the 360-degree concept around it. The trend has been changing from clinical anatomy to conceptual anatomy. So once you're thorough with the concept, whatever type of MCQ is going to be framed, whether clinical scenario, indirect MCQ, extended matching or image-based question, you'll definitely get it right. So what is all this session about? In this session, guys, okay, so as I told you, I've selected images from all these regions: upper limb, lower limb, abdomen, head and neck, neuroanatomy, thorax, histology, embryology, osteology, radiology. Okay, from the high yield topic, previous year questions. And at the end of 1.5 hours or 2 hours, you'll be like getting to see at least close to 100 images. Yes, I've tried to pull in all the most important images. So whatever possible in this short duration, yes, we'll make the best use of it. And something that's like very important in anatomy, considering image-based question, is that orientation. Okay, orientation, because especially thorax and abdomen, the image-based questions can be cross-sectional. And while coming to head and neck neuroanatomy, you'll get to see sagittal section, coronal section images. So orientation is going to be like very helpful, and I'm having like a lot of strategies to help you with that. And most importantly, two things for you. Okay. At the end of every region that I'm going to cover, I'm going to give you a list of high yield topics. So that has been asked over the previous years. Okay. If you are going to be thorough with that, definitely you're going to get all the 16 correct in anatomy. Okay. So come on, let's travel together. Okay. At the end of each region, I'm going to give you a list of the high yield topics. And at the end of the session, we have an image-based question quiz for you, right? And the toppers of the quiz, you're going to get reward. What the reward is, let us wait and see. Okay, shall we start? Right. So from an examiner point of view, right? Okay, so whenever we try to frame a question, we try to make the options more confusing, more similar. Yes, but definitely it's not going to be that very difficult if you're thorough with the concept. Can you help me answer this question? Come on. Easy. Muscle that divides the subclavian artery into three parts. What is it? Yes, I'm awaiting your answers. Come on. Excellent, Dr. Selvak. Yeah, Kartika. Scalenus anterior, right? The subclavian artery, Kamalini, very good, doctor. The subclavian artery is divided into three parts by the presence of scalenus anterior muscle. Okay, excellent, Dr. Roja, Uma, Ranjini, very good. Okay, so the options can appear similar, but if you know the concept, it's going to be easy, right? Another question for you. The options, okay, that the correct answer can be hidden. Really, you're able to make out the fourth cat here? How many of you? Yes. Come on, try answering this question. Muscle that is not innervated by the anterior division of mandibular nerve. Come on, I'm waiting. Take your time. Yes, Dr. Subhashri, very good. Okay, the four muscles of mastication, they're going to get their innervation from the mandibular nerve, from the anterior division of mandibular nerve, except one nerve, except one muscle, the medial pterygoid is innervated from the trunk of the mandibular nerve. Okay? Yes, Dr. Abhilasha Sanjay, excellent. Dr. Rabia, good, good, good. Okay? And sometimes the image-based questions, okay, it could be confusing, misleading. You might be wondering what is that they want from you. Let me read it for you. Identify the incorrectly matched pair. Okay? Incorrectly matched pair regarding the nerve injured and the muscle spared in the images given. Right? Recently, over the recent years, they have been given two images in one question. Okay? So we can expect a similar one here. Right? So here, come on, tell me. What is the answer from the chat box? So let me do it. Come on. I told you upper limb is extremely important, right? So here in image A, what is it? Fracture of the surgical neck of humerus. And what do you think is the nerve injured? Come on, Dr. Sharvari Abhilasha. The nerve injured in surgical neck fracture is axillary nerve. Right. Now tell me, does the axillary nerve innervate the teres minor? Of course. Coming to the next one. What is this condition? Fracture of the medial epicondyle. Can you make out the humerus here? This is the radius and this is the ulna. This is the medial epicondyle, right? Fracture of the medial epicondyle. And what is the nerve involved here in fracture of medial epicondyle? It is the ulnar nerve. Ulnar nerve. And now tell me, does the ulnar nerve innervate adductor pollicis? Dr. Subhashri Magesh? Yes, the ulnar nerve innervates the adductor pollicis that adducts the thumb. Coming to the third image, what is this? This is a fracture of the shaft of humerus. And the nerve injured here is radial nerve. And come on, now tell me, does the radial nerve innervate the brachialis? Excellent, Dr. Kamalesh. So this has the proprioceptive fibers to brachialis. Let's move on to the option D. Come on, tell me here. This is the supracondylar fracture of the humerus, more common in children, and the nerve injured here is the median nerve. Does the median nerve innervate pronator teres? Of course, yes. Okay, so here, though brachialis is innervated by the radial nerve, of the four options, we have to choose the best one. Yeah, we have to go with option C, right? So, yes, there will be a confusing state where you have to pick out the best option possible, right? Now, I told you upper limb, you're going to get lot number of questions, right? And these questions, they mainly come from area related to nerve injury, brachial plexus. So in today's discussion, I've taken like 4 to 5 questions from upper limb. Yeah. involving nerve injuries. And what you're going to do is guess the nerve in each scenario, each image-based question. Shall we start upper limb now? Come on. I'm waiting for your answers. These are the three clues. Yes, Dr. Abhilasha, Kamalesh. Come on. So what is image A, B, and C trying? Very good, Dr. Sharwari, Dr. Sai Kumar. Excellent, right? The rounded contour of the shoulders by the deltoid muscle. The upper lateral part of the arm, it is going to be innervated by a branch of the axillary nerve. And here, can you appreciate? This is the right upper limb and left upper limb. The left upper limb, the patient is able to abduct up to 90 degree, but not the right. Okay. Excellent, excellent, Dr. Subhashri, Dr. Selva. All right, it's just picture based, but all these are important. In this picture, can you pick out the axillary nerve here again? This is the axillary nerve. This axillary nerve is coming from the posterior cord with the root value C5, C6. Can you identify the two muscles innervated by axillary nerve in this image? I'll put A, B, C, D. Come on, tell me, okay? What are the two muscles innervated by axillary nerve in this image? Excellent, Dr. Selva. Excellent, right? So what you see here is the spinous process of scapula. Above the spinous process, this is the supraspinatus muscle. Below the spinous process is infraspinatus muscle. Okay? And this one reflected down, this is the deltoid. Excellent, Dr. Uma Ranjan, Abhilasha. Yes, Uma Ranjani, you're closer to the answer. Just one correction. This is the teres minor and D here is the teres major. Please make a note of it. And guys, those who want a copy of this written PDF, enter in the chat box, okay, whether you need it or not. Yeah. So please make a note of it. The axillary nerve innervates the deltoid and the teres minor muscle. It's not that you should know the names of it alone. You should be clever enough, smart enough to identify the muscles in the image, right? Yeah. And as I told you, the upper lateral part of the arm, yes, the axillary nerve, it gives a separate branch. Now, can you tell me what are the conditions in which the axillary nerve can get injured? Because a case scenario can be framed with that. Yes, please make a note of it. Fracture of the cervical neck, right? And then, yes, any other example related to humerus? Anterior dislocation. Okay, those who want the written PDF of it, write your name and your mail ID also. Okay, we'll get it back. We'll ask the team to send it to you. Anterior dislocation of the humerus. And of course, very good, Dr. Abhilasha, intramuscular injection into the deltoid, not in the right position. Okay, it can injure the axillary nerve. So that's about the axillary nerve. Come on, read this question for me. Patient presenting with the deformity shown in the image will have normal functioning of. Yes? What is it? Come on. Patient presenting with the deformity. What is the deformity that you see here? Excellent, Dr. Selva. Yeah, the condition shown here is the wrist drop. Yes, excellent. But read the question properly. Patient presenting with a deformity shown in the image will have normal functioning of. So what are they trying to tell by that? The nerve injured here is the radial nerve. So which of the following muscle is not innervated by the radial nerve? Come on. That is what they want, okay? Of the four muscles, which one is not innervated by the radial nerve? It's easy. Yes, yes, Dr. Janet, excellent. The pronator teres is going to be innervated by the median nerve, right? So please remember, you can get a same thing in a case scenario, but the examiner would like to change the word from the wrist drop. And the alternate word that can be used is patient is not able to dorsiflex the wrist. Patient is not able to extend the wrist. Okay, but you should be clever enough. And must know what are the branches of the radial nerve, because as far as radial nerve injury is concerned, the level of injury is very important. Okay, while in the axilla, please understand, we can easily remember the branches of the radial nerve, LMP. While in the axilla, the radial nerve gives three branches: to the long head, to the medial head of triceps, and one cutaneous branch, posterior cutaneous nerve of arm. While in the spiral groove, it gives two muscular branches and two cutaneous branches. What are the muscular branches? Once again, to the medial head of triceps that innervates anconeus, and then to the lateral head of triceps. The two cutaneous branches are going to be the lower lateral cutaneous nerve of arm, posterior cutaneous nerve of forearm. And this is again important. Before termination, the radial nerve innervates the brachialis, brachioradialis, extensor carpi radialis longus. Yes, the level of termination of radial nerve, anyone? What is the level of termination of the radial nerve? Opposite the lateral epicondyle of humerus, it will divide into a superficial branch and the deep branch. The superficial branch is entirely cutaneous, and the deep branch, which we call it as the posterior interosseous nerve, is entirely motor. Okay, right. This posterior interosseous nerve is responsible for extension of your metacarpophalangeal joint, right? You know, this knuckle joint is the metacarpophalangeal joint. I have one question for you. Let me see who's smart enough. Come on. What are the muscles responsible for extension of your interphalangeal joint? I'll repeat that again. Okay. The muscle responsible for extension of interphalangeal joint is excellent, Dr. Rabia and Janet, right? It is the lumbrical muscles that are innervated by median nerve and ulnar nerve. So please understand, the radial nerve has no role over extension of the interphalangeal joint. It's under the control of ulnar nerve and median nerve, right? So these are the conditions in which the radial nerve can be injured: crutch palsy, fracture of the shaft of humerus, intramuscular injection into the deltoid in the wrong place, Saturday night palsy. You see a picture of wrist drop, and just 2 years back, okay, they gave a picture, this picture in the NEET PG entrance examination. What is this? For correction of wrist drop, okay, this is the cock-up splint used to treat radial nerve injury, to treat wrist drop, right? So this was asked just 2 years back. So everything about the radial nerve is extremely important. Come on, let's move on to the next question. Cadaveric images again is very, very, very important, okay? Yes. Injury to the pointed structure, patient will present with difficulty in. It's a relatively easy question. Come on, let me see who gets it first. You want me to zoom it? Tell me, what is the structure pointed out? The structure pointed out here is, so it is an image of the cadaveric image of the pectoral region, isn't it? And this nerve that you see running here over the pectoral region, over the serratus anterior muscle, is the long thoracic nerve, right? So can you make out the serratus anterior muscle here? These are the digitations of the serratus anterior muscle. And this is the long thoracic nerve. What is the action of serratus anterior muscle? Protraction, right? So injury to the long thoracic nerve, paralysis of serratus anterior, patient not able to protract. Okay, so if I ask you directly, what is the winging of scapula, you'll be able to tell. But this, I've taken it to an image-based question. Okay, so this is again very important. You know that this condition is winging of scapula where the medial border is becoming more prominent. What is the reason for medial border becoming more prominent? Anyone? Yes. Why is the medial border prominent? What is inserting into the medial border? The medial border receives the insertion of the rhomboids minor and major, which are the retractors, right? Your protractor is paralyzed, so the retractor works hard and the medial border becomes prominent, leading to winging of scapula when the patient is trying to protract. Understood? Now here, why did I choose this image was like recently they asked, okay, I'll come back to it. Now, can you identify the long thoracic nerve here? Again, this is the serratus anterior muscle and this nerve that you see over here, this is the long thoracic nerve. In this same image, come on, try to identify these two structures. It's easy again. I'll mark it A and B. What is A? What is B? Brachial plexus, branches of the brachial plexus, both. A is piercing your coracobrachialis. What is that? Piercing the core. Excellent, Dr. Inia. Yes, thanks for the try, Dr. Sharwari. This is the musculocutaneous nerve, right? Piercing the coracobrachialis. What could this be? It is formed by the union of two roots, the median nerve, right? So I think like image based question, even a single thing like it can look complicated, but it's actually going to be very easy. Now this one, if you understand the concept, it's going to be very easy. This B was the recently asked a last year NEET PG question, a cadaveric image where the structure B was marked. Can you tell me what nerve could be? So I'll just orient you to this image. What are the muscles you get to see here? This is the pectoralis major. If the pectoralis major is removed, underneath it you get to see the pectoralis minor, right? And this is the serratus anterior. This is latissimus dorsi. This is your teres major, right? Now, is that helpful? Come on, let us identify the nerves. Excellent, Dr. Jessica. B is the nerve piercing pectoralis minor is medial pectoral nerve, right? And A, piercing the clavipectoral fascia, lateral pectoral nerve. C, just now we saw, right? C is the long thoracic nerve. What about D, right? D is ending in latissimus dorsi. What is the nerve supply to latissimus dorsi? Thoracodorsal nerve. E ending in teres major, the lower subscapular nerve. Okay. So if someone is going to ask you what is the nerve supply to latissimus dorsi, it will be easier for you to tell. But in an image-based question, you should be like smart enough to identify it. Right. Coming to G, yes, this is your musculocutaneous nerve. And this I told you, right, formed by the union of two roots. This is the median nerve. So this one image, right, you get to see most of the nerves in the upper limb. Excellent, right? Thank you, Dr. Harsh Patel. Okay, so this is an extremely important image. If you're able to understand the concept behind it, where is the each muscle located? Where is the nerve running in respect to the each muscle? And what is the nerve supplying that muscle and the action of that muscle? So many questions can be framed in this one single image. Okay, I put a question for you. Let me see how many of you get it right. Come on. That same image. Now you'll be able to tell what is the nerve marked, right? So this is image A, this is image B. Injury to the pointed structure in image A will present with loss of sensation over. The nerve injured in image A is musculocutaneous nerve. Where is the sensation lost. Please remember the musculocutaneous nerve is called musculocutaneous because it supplies the three muscles in the arm: coracobrachialis, brachialis, biceps brachii, and then continues into the forearm as lateral cutaneous nerve of forearm. So this area, okay, there is loss of sensation. Okay, so again, NEET PG point of view. Sensory innervation of the hand is extremely important. I am sure you are thorough with it. So now help me write this. What is A, B, C, D, E? A, right? Palmar surface, lateral 3.5, shown in blue color. Yes, come on. A is excellent, Dr. Kanchan, Harsh Patel. Excellent. Median nerve. Excellent. B, both on the palmar surface and on the dorsal surface, you get to see the pink color. 1.5, medial 1.5. This is the ulnar nerve. And this green color shown over the dorsum, 3.5. Also over here, lower lateral cutaneous nerve of arm is the radial nerve. And the brown color regimental badge of anesthesia, upper lateral cutaneous nerve of arm. Excellent, Dr. Selva. This is the axillary nerve. What about this purple? That is what we saw in this question. Lateral cutaneous nerve of forearm coming from the musculocutaneous nerve. A lot number of case scenarios can be like framed using this concept, okay? So patient with median nerve injury, loss of sensation over. Patient with a fracture of the mid shaft of humerus presented with loss of sensation over. Right? Each nerve injury, the loss of sensation in a particular area itself can help you to arrive at the diagnosis, isn't it? Come on, next question. Again, this is a high yield topic which they've asked repetitively over the previous years. These tests are done to diagnose. What are these tests? Can you help me name them? A, these tests individually they've been asked, right? A, B, and C. Yeah, excellent. A is the Fallon test. B is Tinel. C is Durkheim test to diagnose. Yes, low median nerve injury. Injury to median nerve in the carpal tunnel. Carpal tunnel syndrome. These three tests are diagnostic of carpal tunnel syndrome. And Durkheim test, they have been asking it repeatedly over the last 2-3 years. Okay. And of course, you know, median nerve injury. Yes, atrophy of the thenar muscles. Can you tell me what are these two tests, A and B? A and B. Come on. This one also they have been asking repeatedly. This test A is the pen test. Yeah, pen test and OK sign, right? Please understand the pen test is for median nerve to diagnose the paralysis of abductor pollicis brevis. Any other abductor, you know, for the thumb. Abductor pollicis longus is innervated by radial nerve, okay? It's not for that. It's exclusively for abductor pollicis brevis. And Kilonevin sign, the OK sign. You're able to make a perfect OK by bending your thumb and the index finger because of the flexor pollicis longus and flexor digitorum profundus of the index finger that are innervated by the anterior interosseous nerve, right? This has been asked in your last NEET PG entrance examination. So please make a note of it. Median nerve. What are the muscles innervated by the median nerve in the forearm, in the hand, and the muscles innervated by the anterior interosseous nerve? Right? So when you get a copy of this written PDF, it will be helpful for you for your rapid revision. Okay. Now coming to I think this is the last question in upper limb. Okay. Come on, let's do it. What is this nerve pointed out? What is this nerve pointed out? Come on. Excellent, excellent, excellent. This is the ulnar nerve, isn't it? This is the ulnar nerve. This is the ulnar nerve. Now come on, identify the muscles A, B, C, and D. What is this muscle A? A is the first dorsal interossei. Okay, guys. So this is one, yeah, that is what I want you to understand. Here you're seeing the dorsum of the hand, right? And this space is this, what you see here is the dorsal interossei. Okay. And here, what is B? Abductor digiti minimi, your hypothenar muscle. C is the second lumbrical. And D here is the adductor pollicis. Now, can you give me the answer? Injury to the ulnar nerve leads to paralysis of all the muscles except. Yes, what is the muscle which is not supplied by the ulnar nerve here? This is the dorsal interossei. B is your abductor digiti minimi. C is the second lumbrical. And this is your adductor pollicis. Which one is not innervated by the ulnar nerve? Excellent, Dr. Rabia. Very good. Okay. So by now you should have in your tip of your fingers the muscles innervated by ulnar nerve, median nerve, and radial nerve. Okay. The first and second lumbricals are innervated by the median nerve and not ulnar nerve. So this is a list of muscles innervated by the ulnar nerve in the forearm and hand. Please remember the third and fourth lumbricals alone innervated by the ulnar nerve. First and second lumbricals, median nerve. All the interossei are innervated by the ulnar nerve. Okay, another easy question. Yes, because upper limb is very important. I couldn't want to miss any question. Okay, come on. Of course, you can take it for I'm sure 100% everyone know what is this condition. This condition is the policeman tip, the waiter's tip, Erb's palsy. Right? It's a very simple question, right? Yeah. What is the nerve spat in this condition? From your first MBBS, you have been learning about Erb's palsy, Erb's palsy. A very easy question. What is the other palsy related to brachial plexus injury? Klumpke's, right? Yeah. So what are the nerves involved in Erb's palsy? I'll give you an easy clue to remember. Please remember this. Manners, musculocutaneous nerve, axillary nerve, nerve to subclavius, radial nerve, suprascapular nerve. Okay. Now can I go back to the question again? Come on, give me the answer now. Which option? Excellent, excellent. All of you getting it right. Okay, it's that easy. It's that easy. Median nerve and ulnar nerve, right? They are involved in Klumpke's palsy. It is the same Erb's palsy that I've been learning. And it's all actually an easy question only, right? Okay, just that, yeah, you got this very tip. Hope it was useful for you. So shall we wind up with the upper limb for now? So now you can take a screenshot of this page because there might be a delay in sending the written PDF, right? By the time you can make a screenshot of this page, right, please? Where I have listed, yeah, all the high yield topics, okay, and the previous year question that you should not skip before your examination. So please make a note of this and give an extra attention to this. Is that okay? Coming to lower limb, paralysis of the pointed muscle in image A can present with loss of sensation over which area in image B. So it is leg, front of leg. What is this muscle that is there? Name the muscle. The muscle that you see here is it is an important muscle. Excellent, Dr. Abhilasha. It is the tibialis anterior, right? And you know all the muscles in the front of the leg, they are going to be innervated by the deep peroneal nerve. Am I right? So injury to the deep peroneal nerve, paralysis in the muscles in the front of the leg is going to lead to foot drop. That's a very high yield topic, right? and loss of sensation over the first web space, dorsum. So, yes, this is the territory of the saphenous nerve. We learned about the cutaneous innervation of the hand, right? Similarly, cutaneous innervation of dorsum of foot is extremely important, right? The first web space is deep peroneal nerve. Superficial peroneal nerve innervates most of the skin over the dorsum of the foot, and tibial nerve gives a branch called the sural nerve that innervates the skin over the lateral border and the little toe. Again, a lot of case scenarios can be framed related to these nerve injury, and loss of sensation can be a clue to pick out the diagnosis. Okay, a high yield topic. So this you can make out, right? This is your right foot and left foot. Which one is abnormal here? Right or left? Excellent, excellent, Dr. Umar Ranjani, Dr. Selva, Jessica, Kartika, excellent. So inability to dorsiflex, foot drop, that leads to high stepping gait. Okay, so here again, everything, each word here is important in this page. Fracture of the neck of the fibula, because the neck of the fibula, the nerve winding around in this is common peroneal nerve, and its branch, deep peroneal nerve, supplies the muscles in the front of leg. Injury to it, foot drop and loss of sensation over the first web space. Patient is present with high stepping gait. This is what I called it as 360-degree concept of the high yield topic. So whether it's an image-based question or a different sort of clinical case scenario, right? Whatever type the question is framed, you'll be able to get the answer right. So this is all you should be able to know in relation to foot drop, high stepping gait, deep peroneal nerve injury. Come on, the next high yield topic in lower limb. Image A, muscle paralyzed in this condition. Here, this is the right and this is left, right? The patient is lifting the left foot off the ground, and you can see the tilting of the pelvis on the left side. What is the nerve injured? What is the muscle paralyzed? Of course, Dr. Madhumita Umaranjani Selva. Of course, it is the Trendelenburg gait. Which side nerve is injured? Which side muscles are paralyzed? Left or right? If there's tilting of pelvis on the left side, right, it is the right side, superior gluteal nerve. And yes, the muscles innervated by it. Come on, now help me identify the muscles here. What is A, B, C, and D? So you're going to tell, I'm going to write. What is A? A here. A here is gluteus maximus. C, underneath the gluteal upper neurosis is gluteus medius. And this one here, right? This is the gluteus minimus. Over here, this one going towards the iliotibial tract, D is the tensor fascia lata. So B, C, D, all these three are innervated by the superior gluteal nerve. Okay, and these three muscles are the abductors and medial rotators of the hip. Okay, so this is again a very important topic. You should be able to identify in the image, okay, whatever it is related to the topic. So this is your piriformis muscle, isn't it? This nerve is the superior gluteal nerve. And this is the inferior gluteal nerve innervating the gluteus maximus, that is the lateral rotator of the hip joint. Okay, so this again is a high yield topic, highly expected question each year, every year. Yes, related to knee joint. Which of the following labeled is, it's very easy. Okay, it's very easy. Just stay with me. I'll make it easy for you. Which of the following labeled structures contribute to the O'Donnell triad? Anyone can tell me what is the other name for O'Donnell triad? It is also called as the unhappy triad. What are the three structures? What are the three structures involved in this unhappy triad? This is the mnemonic I have for you to remember the structures involved in unhappy triad. ATM. I'm sure lifelong you're not going to forget it. Anterior cruciate ligament, tibial collateral ligament and the medial meniscus. Okay, now you know it, how to identify it in the image. Now you have to orient to the image, right? So here, let us make out the anterior posterior. What you see here is the tibial tuberosity. This is anterior. This is posterior. This one, which is small and circular, this is longer, right? This is the medial meniscus. This is the lateral meniscus. Okay, F is medial meniscus, D is lateral meniscus. So this is medial and this is lateral. Now you're able to orient, then the things get easier after that. Okay, so this is going to be your anterior cruciate ligament in front. This is the posterior cruciate ligament. This I told you is the medial meniscus, and this closely adherent to the medial meniscus is the tibial collateral ligament. But away from the knee joint here is the fibular collateral ligament. This tendon that you see here behind the medial meniscus, this is the tendon of semimembranosus, right? And this one here is the tendon of popliteus. Is that okay? Yeah. Now come on, tell me. Yes, just by looking into it, what will be the answer? E, F, and G. Now tell me, why are they all closely linked? Yeah, medial meniscus and tibial collateral ligament, they are adherent together. What about the anterior cruciate ligament? You know, the knee joint is a modified hinge joint because you can flex it, extend it. At the same time, there's some amount of rotation taking place there, isn't it? And this anterior cruciate ligament, it forms the vertical axis for the rotational movement taking place at the knee joint. That is why it is subject to wear and tear more commonly than the posterior cruciate ligament. Is that fine? Okay, so make sure you're not going to forget it. Right. So the amount of high yield topics in lower limb is comparatively lesser when compared to upper limb. Okay, but sometimes 1 year, like the last before year, the most unexpected question came. Okay, that topic will not touch even in first MBBS. A question from the soul appeared for the first time in a NEET PG entrance examination, asking about the medial plantar nerve and lateral plantar nerve and the muscles innervated by it. So it is definitely mandatory for you to know the muscle name, the nerve innervating it, and the action of that muscle, and identifying the nerve and the muscle in an image too. Okay. Now come on, help me identify this. A, B, C, D. So here again, orientation, you're able to make out the great toe. It's going to be medial and this is lateral. This one, going for the little toe, A is the abductor digiti, okay? And D is the flexa digitorum brevis. C, DD. C is the, second lumbrical, okay? And B here is the third lumbrical. Now, can you help me with the answer? Medial plantar nerve innervates. So in upper limb also 4 lumbrical, in lower limb also 4 lumbrical. But what is the difference? In upper limb we saw that the median nerve will innervate first and second lumbrical, and ulnar nerve will innervate the third and fourth lumbrical. Am I right? Okay. Here, please remember the medial plantar nerve. It innervates the, on the whole, only 4 muscles in the sole. Okay. The first lumbrical, abductor hallucis, flexa digitorum brevis, flexa hallucis brevis. The second, third, and fourth lumbrical are innervated by the lateral plantar nerve. Okay. So here the answer, as you see here, it's going to be Flexa digitorum brevis. This is a tricky one. That's why I want to insist it. Okay. So you should know the name of the muscles in each layer of the sole. Its nerve supply. As you see here, more number of muscles are innervated by the lateral plantar nerve. So it's easier to remember the muscles innervated by the medial plantar nerve. It's only 4. And the tricky part is over that lumbricals area. Is that fine? Okay. Now, yes, I want you to take a screenshot of this page, the high yield topics in lower limb that you should be definitely thorough of before you sit for your entrance examination. Done? Okay. So moving on to thorax, right? Thorax, 1 or 2 questions come, and usually cross sections, questions of cross section. This is actually a very easy, this came in the recent INI-CET entrance examination, right? I've just modified it a bit. Now, again, before going to the options, can you help me identify what is A, B, C, and D? The appearance differ about like taken at which part. So here orientation, these cross sections, imagine you're standing at the foot end of the patient, right? So here anterior posterior is not going to be a big thing. This is the sternum. So this is anterior. You can make out the vertebra here. So this is posterior. What about the right and left? I told you you're standing at the foot end of the patient. This is going to be right and this is going to be the left. Right. Now here, which one do you think is more muscular? Which one is more muscular here of A, B, C, and D? This is the left ventricle, right? This is more muscular. And here, this B here, this is the right ventricle. This is the right atrium. This is the left atrium receiving the pulmonary veins. Okay. Now look at the options. A, B, C, D. A is right atrium. B is right ventricle. C is left ventricle. And D is left atrium. Now it's easier to do the options. Right atrium doesn't receive oxygenated blood. Right ventricle undergoes hypertrophy on pulmonary stenosis, right? Esophagus will form the posterior relation for the left atrium, not the left ventricle. And D, yes, the left atrium will not give rise to the ascending aorta, okay? So if you could identify, the option becomes very easy to, okay? So all the thing is related to identification. And now a similar one. Now come on, identify here. So here again, this is anterior, this is posterior, right and left. Yes, here again, this is the trachea. Can you make out the muscular nature here? This is the esophagus, right here. And this is the superior vena cava. And this is the arch of the aorta with its 3 branches, the brachiocephalic trunk, the left common carotid, and the left subclavian artery. Okay, yes, Dr. Sneha. Yes. So cross sections of thorax, when you do a repeated revision, you become like excellent with it, right? Once you understand and do it, it's going to be easier, easier, easier. Trust me. Okay. So thorax, you should be mentally prepared, like to expect a image on cross section. Another easy question from your previous NEET PG examination. All the following arteries, they supply the market part except. Now come on, tell me, what is the market part here? Help me identify it. So come on, help me. Yes, excellent, you're right. This is the right ventricle. This is left ventricle, right auricle, left auricle, the aorta and the pulmonary trunk. Now the question should be easier. All the following arteries, they supply the market part except. All the following arteries, they supply the market part except. Yes, excellent, Dr. Madhumita. Madhumita, yeah. Yeah, the marginal artery is again a branch of the right coronary artery. So this is your right coronary artery. This is your marginal artery. This is the anterior interventricular artery. Here again, you'll get to see the right coronary artery. The diagonal artery, it arises from the anterior interventricular artery or the left anterior descending artery. And yes, it supplies exclusively the left ventricle. Okay, but the branches that arise from the right side of the anterior interventricular artery will supply the sternocostal surface of right ventricle. You should have that in your mind. Okay, so diagonal branches, they supply the left ventricle. Okay, to identify the branch of it. Okay, yes, here. So here, please identify the arteries here. This is the right coronary artery. This is the right marginal artery, right? And here, this is the left coronary artery. This is your left anterior descending. These are the diagonal branches. Can you tell me what are these branches? The question mark, those are the obtuse marginal. Excellent. Those are the obtuse marginal branches arising from the left coronary artery. Okay. All right. Another simple way is we can upload this PDF into our DigiNerve app. I'll ask to the team, okay? We can upload the written PDF into the DigiNerve app, right? And you can get access to this written PDF through the DigiNerve app itself, right? I'm sure all of you would have downloaded the DigiNerve app, right? It's from the Play Store, okay? Through the app, we can upload it into the app and you can access it in the app, right? That will be an easier way, right? Okay. So this artery is the posterior interventricular artery, right? So you should be able to identify the branches in the image. And again, this is again important, right? The right coronary artery and left coronary artery distribution. Please make a note of it. It's extremely important. Right coronary artery, it supplies the right chambers, right atrium, right ventricle. Apart from that, it also supplies the left ventricle, the diaphragmatic surface. Similarly, left coronary artery supplies the left chambers, left atrium, left ventricle, and also the right ventricle sternocostal surface. And again, coming to the septum, interventricular septum, the right coronary artery through the posterior interventricular artery supplies postero-inferior one-third of the interventricular septum, whereas through the anterior interventricular artery, the left coronary supplies antero-superior two-third of the interventricular septum. Coming to the conducting system, the blood supply is important. SA node, AV node are mainly supplied by right coronary artery. The bundle of his left bundle branch can get blood supply from both right coronary and left coronary. But please make a note of it. The right bundle branch is going to be exclusively supplied by anyone. Right bundle branch gets its blood supply exclusively from, excellent Dr. Harsh Patel, left coronary artery. Okay. So again, these are the, like, everything is vast, right? We cannot do it in a 1 hour or 1.5 hours. Okay. So these are the high list topics, high yield topics in thorax that you should not skip before your exam. Moving on to abdomen. Okay. Abdomen, just two questions I put, but two important questions. Come on, let's do together. The pointed structure in the given image is, what is this is, and what is it a defect in? Come on, the arrow is pointing at. The arrow is pointing at what surface marking is this? The deep inguinal ring. Excellent, doctor. Right, the deep inguinal ring. Where is the deep inguinal ring? This is your antero-superior iliac spine, right? Antero-superior iliac spine. This is your pubic symphysis. Midpoint, right? It's not the inguinal ligament, okay? Pubic symphysis. Midpoint between the ASIS and the pubic symphysis is the midpoint, mid-inguinal point. Mid-inguinal point, okay? Half an inch above the mid-inguinal point, we get to see the deep inguinal ring. That is a defect in fascia transversalis. Now my next question. Abdomen, please remember the very important topic that's repetitively asked over the years is related to inguinal canal boundaries. Inguinal hernia, right? Okay, so this is a very important topic. Deep inguinal ring location. Where is it in the fascia transversalis? Okay. And what is this vessel that lies immediately medial to it? Easy? Yes, Dr. Alia, Dr. Selva Karthika. Excellent, Dr. Kamalesh. It's going to be the inferior epigastric artery. The inferior epigastric artery, it lies immediately medial to the deep inguinal ring. Now my next question. Where is the neck of the hernial sac in case of direct inguinal hernia? Medial or lateral to the inferior epigastric vessels? Yes, Dr. Kaushik. In direct inguinal hernia, the neck of the hernial sac, it lies medial to it. Indirect inguinal hernia that comes to the deep inguinal ring, lateral. This again, they keep asking repeatedly over the years. Okay. And here, superficial inguinal ring is a defect in external oblique upper neurosis. So this table I prepared for you is again important. Superficial inguinal ring from the margins of it, external spermatic fascia. Deep inguinal ring in the fascia transversalis from the margins of it, internal spermatic fascia. And conjoint tendon, yes, combination of both internal oblique and transverse abdominis. Cremaster muscle, modification of internal oblique. Okay? Again, this is important. This again a previous NEET PG question. I'll read it out for you. 18-year-old male patient was lined up for splenectomy due to ITP. While operating, the surgeon was dissecting the spleen from the surrounding structures, accidentally injured the short gastric vessels, which caused bleeding. These vessels are content of which ligament? Easy. The short gastric vessels are content of, name the ligament in the chat box. Yes, Dr. Selva. Yes, the answer is of A, B, C, D. Which one do you want to choose? Which is gastrosplenic ligament here? A, B, C, D. Excellent, excellent, all of you. It is C. What is A then? What is A, B, and C? Again, orienting to this image, right? So this is going to be, you see the vertebra, it's posterior. This is anterior. You can make out the liver here. Either side of the vertebra, these are the kidneys. The right kidney and the left kidney, right? This is the stomach. This is the spleen. Okay. Now come on. A is going to be falciform ligament that connects the liver to the anterior abdominal wall. What does the falciform ligament contain? Excellent, Dr. Selva. The lower border of the falciform ligament contains the ligamentum teres hepatis. Gastrosplenic ligament, short gastric vessels. Connecting the kidney and the spleen, the lienorenal ligament. That has the splenic vessels, the tail of the pancreas. And lesser omentum, yes, the anastomosis between the right and the left gastric vessels. Whereas the right free margin, what is this green color here? This is the common bile duct. Over here, it is the hepatic artery proper. This one blue. This is the excellent Dr. Harsh Patel. This is the portal vein. Okay, this is your inferior vena cava. This is aorta. Okay, this is again a very, very, very important image. Right. We have so many high yield topics in abdomen. Right. So make sure you're thorough with it. Coming to head and neck is equally important to your upper limb. Okay, due to shortage of time, I've just covered few topics. This again is easy. Come on, we have done it already. Now we're just going to identify it. Which of the following marked structures receives nerve supply from the trunk of the mandibular nerve? We have done it at the beginning, right? You know the answer. Can you tell the name of the muscle? Excellent, Dr. Kamalesh. It is medial pterygoid. Now, all that you have to do here is identify the muscle here. A, B, C, D. Which is medial pterygoid? Yes, Dr. Rabia, Dr. Kartika, Dr. Kamalesh. Yes. So here again orienting to this section. What section is it? It is a coronal section. Can you make out the mandible here? Sitting on outer surface of the mandible, this is the masseter. Coming from up, right? Coming from up and inserting into mandible, this is the temporalis, right? And on the inner aspect of the mandible, this one here is the medial pterygoid. Going towards the, the capsule of TMJ, this is the lateral pterygoid. So if you could see here, this is clear, right? More than that, this is your mandible. So in a coronal section, because in this section, you'll be easy to make it out. But in a coronal section, you have to identify the muscles. All of them are innervated by mandibular nerve. From the anterior division of mandibular nerve, except medial pterygoid. Again, this is a very, very, very important topic. Every year, some question pops from this region. Of the four muscles of mastication, which is the only one that can open your mouth? Yes, a student presenting like yawning in the class and after that couldn't close his mouth. Spasm of lateral pterygoid. Okay, so the action of these muscles, as I've written it here, it is important. Now I put a question mark here. Who's going to help me identify this muscle? This is excellent, Dr. Kanchan. Yes, yes, yes. Very good, Dr. Anurag. That is the buccinator. It's nerve supply. Yes, Dr. Selva, Dr. Kamalesh, Dr. Alia, excellent. This is the nerve supply is by, oh my God, come on. Seventh nerve, right? That's the whistling muscle, trumpeter's muscle, isn't it? Paralysis of this muscle is responsible for accumulation of food particle in the vestibule in Bell's palsy. Okay? Yeah. Lower buccal branch of facial nerve. Excellent, excellent, Dr. Sneha. Now, again, you can take a screenshot of this. This is again important, though it's not related to image-based question. It is a must-know topic, right? All the muscles of the tongue are innervated by hypoglossal nerve except palatoglossus. Palatoglossus is innervated by pharyngeal plexus, okay? The vagus nerve through pharyngeal plexus. All the muscles of soft palate are innervated by pharyngeal plexus via vagus, okay? Vagus, except tensa palatini, that is innervated by mandibular nerve. All the muscles of pharynx are innervated by, again, vagus via pharyngeal plexus, except stylopharyngeus, that is innervated by glossopharyngeal nerve. All the muscles of larynx are innervated by recurrent laryngeal nerve, except cricothyroid, that is innervated by external laryngeal nerve. Just now we have done right all the muscles of mastication by anterior division of mandibular nerve, except medial pterygoid from the trunk of the mandibular nerve. Right? Easy. Now, injury to which of these structures in image A will lead to clinical condition shown in image B? Now, let us look into image B. This is the right eye. This is left eye. A, B, C. A, both the eyes are looking forward. B, both the eyes are trying to turn to the right, but this is not able to adduct, right? Obvious in all the three images, ptosis. This is external squint. Now, come on, this makes it easy. What is the nerve injured? Excellent, excellent, Dr. Rabia. The nerve injured is third nerve. Help me identify third nerve here. Which is the third nerve here? Yeah. So here, this is again an important image. This is your optic nerve, cranial nerve 2. This is your third nerve. This is the fourth nerve. This is the thickest of all cranial nerve, trigeminal nerve. This is the abducent nerve. In the internal acoustic meatus, this is 7th and 8th. In the jugular foramen, this is 9, 10, and 11. In the hypoglossal canal, this is the 12th nerve. Okay. So this again, cranial nerve identification, the skull foramina, again an important topic. Yeah, you can easily score mark in anatomy. Okay, it's going to be easy. It can push your score to a high level. Okay, again, so here, foramen rotundum, foramen ovale, foramen spinosum. Can you tell me what are the structures passing through these? Foramen rotundum, maxillary nerve, foramen ovale, the male structures, mandibular nerve, accessory meningeal artery, lesser petrosal nerve, emissary vein, foramen spinosum, middle meningeal artery, nervus spinosum. Okay? Yes, I'm sure you have to be thorough with this. So A is third nerve injury. B, not able to turn the eyeball down and out. Superior oblique paralysis that is innervated by the fourth nerve. And here, yes, right and left, A, B, C. Okay. So A, both the eyes are looking forward. B, both the eyes are turned to the right. C, the patient is not able to abduct the eye. Not able to turn both the eyes to the left. Not able to abduct. Lateral rectus is paralyzed. Injury to the obtusant. Excellent. Okay. Come on. Identify A and B. What condition is this? Yeah, excellent. Facial nerve injury is again a repeatedly asked question in your NEET PG entrance examination, right? And again, so features of facial nerve palsy, low motor neuron palsy, Bell's palsy. But if the upper face is bad, that's going to be upper motor neuron type of facial palsy. And please remember the skin over the entire face, okay? Skin of the face is going to be innervated by the trigeminal nerve, except over the angle of the mandible, it's by the great auricular nerve. Okay? Muscles of the face, skin of the face, skin over the parotid or the angle of mandible, right? Torticollis. Can you tell me which side sternocleidomastoid has undergone spasm here? This is right and left. Okay. Your sternocleidomastoid turns the chin to the opposite side. Spasm of the left sternocleidomastoid is the right answer. Very good, Dr. Selva, Kanchan, Madhumita. Excellent. A and B. What is the nerve injured? Yeah, this is again important. Okay. So here the uvula, the tip of the uvula is pulled to the normal side. Okay. Left vagus injury. And here the tip of the tongue is, yes, pulled to the paralyzed side. Okay. Yeah. Again, head and neck, very, 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 very important. So many high yield topics there. Interesting. I love head and neck and neuroanatomy. Make sure you like go through all these topics. Make it thorough, okay? Coming to neuroanatomy questions. Again, this is one of your previous year question. Blood supply to pointed areas by what is this pointed area? Which part of the brainstem is it? This will be an important clue for you. What is this structure here? You can make out a crumbled bag appearance. I told you brainstem. There was a clue there. Excellent, Dr. Sneha. Yes, it is the inferior olivary nucleus. Not the, yeah, it is the inferior olivary nucleus in the medulla. The dorsolateral zone, the posterolateral zone of the medulla is supplied by postero-inferior cerebellar artery. That is a branch of vertebral artery. This is again a very high yield topic that they keep asking again and again. What we call it as the lateral medullary syndrome, Wallenberg syndrome, or Pica syndrome. Excellent, Dr. Sneha. Right? Okay. So these are the structures that are involved in the lateral medullary syndrome, right? And the features of lateral medullary syndrome. A case scenario can be framed along it, okay? But you should be able to identify the medulla and that inferior olivary nucleus. Yes, it is an important clue to it. Come on. So here again, right? This is the medulla. This is pons. And this is the region of your crus cerebri, the midbrain. Now, this is the pyramid, which has the underlying corticospinal fibers. This is the olive, underneath which lies the inferior olivary nucleus. What are the cranial nerves related to midbrain? This is the third nerve. This is fourth nerve. This emerging from the surface of the pons, fifth nerve. Pontomedullary junction, this is sixth, seventh, and eighth cranial nerve. Over here, this is the 9th, 10th, and 11th, and this is 12th nerve, right? So emerging from midbrain 3 and 4, pons 5, medulla 9, 10, 11, 12, pontomedullary junction 6, 7, and 8. Okay. Again, this is an important image-based question if you're going to. So this is just a must-know part. Okay, the question can be an indirect one related to nerve injury. But basically, you should be able to identify the nerve, isn't it? Yes, Dr. Kanchan, very good. Again, this again your previous year question. Now it has become very frequent to get two images in one single question. The pointed structure in image A, it projects to which of the labelings in image B? So image A is showing, yes, come on. It's easy to identify, isn't it? This is the gray pigmented band of matter is. So this is a section of the midbrain, right? This is the cerebral aqueduct. In the midbrain, this dark pigmented band of gray matter that you see here is none other than the substantia nigra. So the substantia nigra, it projects to the which part of basal ganglia here? Come on, tell me, identify A, B, C, D. A is caudate nucleus. B here is thalamus, right? I'll put this at C. Okay. C here is which part of the lentiform nucleus? This is the putamen. C will be globus pallidum. And D here is the coiled part. This is the hippocampus, right? Substantia nigra, it projects to caudate nucleus or the putamen. The putamen is not labeled here. So the best choice to go with will be A. Got it? Right? So the caudate nucleus and the putamen together, they are called the striatum. That is the receiving part of the basal ganglia. right? The globus pallidus, all the efferent fibers, they begin from the globus pallidum. Is that okay? Right? So again, images are going to play an important role. Here again, this is a very nice image. Here, this is the medulla. This is pons again. This is the region of midbrain. This is your third ventricle, right? On either side of it is the thalamus. This is the lateral ventricle, right? Here also, can you make out the caudate nucleus here, this band of gray matter? Okay. This is part of your lentiform nucleus. This coiled part, this is the hippocampus. Okay. Can you identify substantia nigra here? I'm just zooming out the midbrain part. Can you make out the gray part here? And one more interesting thing I'm going to show you here. Yes. What is this one? Come on. Yes. In the midbrain, I'm showing it in red color. It is highly vascular. It contains lot of iron pigment. Excellent, doctor. Dr. Kamalesh, Dr. on Monk, Rabia, Sneha. Excellent, excellent, Inia. This is the red nucleus, okay? So midbrain is very important. Cerebral aqueduct, the substantia nigra, the red nucleus, all that you should be able to identify. What is this pointed structure? This again is a frequent question. You want me to erase it so that you can see it better? What is this pointed structure? Excellent, excellent, excellent. Okay, they keep on asking this question again. What is the blood supply to this fornix is mainly from the anterior cerebral artery that supplies the medial surface of the brain, cerebral hemisphere. Okay, so again, there is a huge number of topics in neuroanatomy. My favorite, which is your favorite? I don't know whether anatomy is your favorite subject, but which part of anatomy do you like very much? Yes, come on, tell me. Which part of your anatomy is favorite? I love head and neck and neuroanatomy very much, right? Head and neck and neuroanatomy is really interesting. If you could understand, you will love it. Okay? Yeah. Yeah. But once you get used to it, it becomes more easy. Moving on to every paper is going to definitely contain one question from, yes, Dr. Sandhya, nice to know that you like upper limb. Nerve injuries are very important. One question, at least from histology, keeps popping up. Come on, help me identify. Lymph node and thymus. Which is which? A is not a difficult one. Yes, A is thymus and B is lymph node. Here thymus, if you see, these are all thymic lobules. Each one is a lobule. Each lobule, if you see, it will have an outer darker cortex and inner medulla is pale. And if you zoom a bit, in the medulla, these pinkish structures, they are going to be called the Hassel's corpuscle. Similarly, here in the lymph node, you have a capsule. This space that you see here beneath the capsule, it's the subcapsular sinus. In the cortex, you get to see the lymphoid follicle. This is the region of the medulla, where you have the medullary cords of lymphocytes and these empty spaces that's appearing white, right, between the medullary cords. That is the medullary sinuses. Okay, not difficult. This one, which is glenoid labrum and which is thyroid cartilage? Yeah. So come on, tell me what type of cartilage it is. Glenoid labrum is made up of, yes, glenoid labrum is made up of fibrocartilage. Thyroid cartilage is hyaline cartilage. Okay, so if I asked you which is hyaline or fibro, you would have made it easier. But always you can expect the unexpected, isn't it? Hyaline cartilage, there are these cell nest basophilic homogeneous matrix, perichondrium will be present. Fibrocartilage, no perichondrium, just bundles of collagen fibers. Okay, fibrocartilage, make sure you know it is present in glenoid labrum of the shoulder joint, acetabular labrum. Yes, Dr. Sneha, acetabular labrum of the hip joint, intervertebral disc, and the menisci of the knee joint, right? Hyaline cartilage, on the other hand, trachea, cartilages of the larynx, thyroid cartilage, cricoid cartilage, most of the arytenoid, all that is made up of hyaline cartilage. Epiphyseal growth plate, right, in the developing bone, examples of hyaline cartilage. Yes, this was asked in the recent INI-CET question. Which is terminal bronchiole? Which is respiratory bronchiole here? Yes. Okay. Yeah. Right. Terminal bronchiole, respiratory bronchiole. This part, histology of lung, they keep asking again and again. And in our DigiNerve app, right, we have discussed it in detail. And this might help you. Mhm. Here, right? So you know the trachea is going to have a mucosa lined by pseudostratified ciliated columnar epithelium with goblet cells, submucosa with the seromucous glands, and then the hyaline cartilage, outer adventitia serosa, right? Adventitia. And then you have the bronchus. Once the bronchus enters the lung, the hyaline cartilage, it breaks. You get to see irregular plates of hyaline cartilage. And then the bronchus narrows down to the bronchiole. Please understand, in the bronchiole, there is not going to be any cartilage. There is no cartilage component. Okay. Instead, smooth muscle layer becomes more prominent. Here, can you make out the smooth muscle layer? Right. And how to differentiate the terminal bronchiole and respiratory bronchiole? The wall of the respiratory bronchiole is interrupted by the opening of alveoli. Okay, that you can obviously make it out. Respiratory bronchiole, the wall is interrupted by the opening of the alveoli. And please remember why this becomes important. The junction of the terminal bronchiole with the respiratory bronchiole. Yeah, the terminal bronchiole corresponds to the conducting portion of the respiratory tree. And the respiratory portion begins after the termination of the terminal bronchiole. Okay, so this juncture is important. And if you're really interested in this, please take a screenshot of this. It will be of extremely useful. Okay, please take a screenshot of this. The difference between primary bronchus, intrapulmonary bronchus, terminal bronchiole, respiratory bronchiole, alveolar duct, the type of cells in the alveolar sac. Right? So these are again high yield topics in the histology portion that you should definitely know. Coming to embryology, it's easy. Come on, tell me. Derivatives of the pointed structure includes all except. What is the pointed structure? This again is a repeat topic here. This is the neural tube. This is the notochord. This is the surface ectoderm. This is the endoderm. Either side of the neural tube, what you see here, this is the paraxial mesoderm that forms the somites. This is the intermediate mesoderm. The lateral plate mesoderm presence of the intraembryonic coelom is divided into outer, yes, somatopleuric mesoderm and inner splantopleuric, right? This pointed structure is the neural crystals. Neural crystals. So they've asked you, right? All these are derivative of the neural crystals except what is the answer? By now you should have it at the tip of your fingers. Come on. Amyloblast are not derived from the neural crystals. It is the odontoblast, right? So here again, I've put a list for, the derivatives. Embryology is all about derivatives and remnants. Derivative, what are the remnants of the notochord, derivatives of the ectoderm, endoderm, the types of mesoderm, all that is extremely important. Okay, and make sure the derivatives of the neural crystals, they keep asking repeatedly. Can you identify these clinical conditions which have been asked repetitively over the previous years? Come on. A, B, C, D. What is A? Excellent. A is ectopia vesicae. B is exomphalus or omphalocele. Yes, Dr. Rabia, Dr. Madhumita, Dr. Sneha. C is gastrochysis. D is sacrococcygeal tumor. Ectopia vesicae is the lateral foldings, they do not approximate. Below the umbilicals, that is deficiency of mesoderm. The anterior wall of the bladder is not formed. Mucosa of bladder is exposed. Okay. Coming to omphalocele, failure of the midgut loop to return into the abdominal cavity. This was a recent question. They was asking about the covering. This is the amnion, right? So the midgut loop, it doesn't return. It lies outside. Okay. Bladder exostrophy is for A. Yeah. Ectopia vesicae is the same as bladder exostrophy, right? Omphalocele, failure to return. Gastrochysis, you don't see the amnion covering, you see part of the intestine out. This is due to defect in the anterior abdominal wall. And it doesn't come through the midline like the exomphalus. It mostly lies to the right side. Sacrococcygeal tumor, another frequently asked question. It is a tumor coming from the remnants of primitive streak. So an image of the primitive streak can be given, right? And you can be asked to identify. So these are all like very, very, very high yield topic in embryology. Again, another topic. Can you identify the congenital anomaly here? Connecting the pulmonary trunk to the distal part of the aortic arch. Patent ductus arteriosus. Now give me the answer. Yes, Dr. Rabia. Which is the correct option? This congenital anomaly results due to defect in excellent, right? Sixth arch artery on the left side. So this is the ductus arteriosus. It should obliterate if it persists again. Patent. So again, pharyngeal arch arteries, their derivatives is very, 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 very important. I've tried to simplify it using this table. Make use of it, okay? Again, these are all the high yield topics in embryology that you should be definitely thorough of. So that will give you a lot of confidence if you've read through this. Osteology, one important thing that you're very obsessed with. Yes, come on, what is this? The pterion. What are the four bones contributing to the pterion? The frontal bone, the parietal, the temporal, and the greater wing of sphenoid, isn't it? And what lies on the inner surface of the pterion? Anterior division of middle meningeal artery. What type of hemorrhage results from it? Extradural hemorrhage. Okay. And here it corresponds to the stem of lateral sulcus. So sometimes, they keep asking it repeatedly, this topic. And this was in your recent INI-CET question. It was marked here. They were asking about the action of the muscle here, right? Gluteus maximus. Now I put a similar question here. Try doing it. Action of the muscle attached to the pointed area. We have seen it in this session. The muscle attached here is, it is the lateral border upper. Excellent, Dr. Selva. What is the answer then? The teres minor is a, excellent, Dr. Inia, lateral rotator of the arm, right? Just giving you a concept of how the image can be questioned, right? Radiology, we have seen through this, right? Coming to this one, identify the correctly matched. This was also asked recently asked. Correctly matched. What is A, B, C, and D? Come on here, we'll do it. So here, this is the common carotid dividing into external carotid and internal carotid artery, right? This is the ascending pharyngeal. Going down is the superior thyroid. This will be the lingual artery. This is facial artery with a cervical loop. Okay. And over here, this is going to be the occipital artery here. Okay. And this is the superficial temporal. This is maxillary artery. This one going up from the maxillary artery, any idea what it is? This is the middle meningeal artery. And over here, this is the anterior cerebral artery turning around the genu. This is the middle cerebral artery. Do you want me to repeat it again? Shall we do it once again? Right. So here again, common carotid, internal carotid, external carotid, superior thyroid. Sorry, here. This is the superior thyroid. This is the ascending pharyngeal, lingual artery, facial artery, maxillary artery, superficial temporal artery, middle meningeal artery, right? This will be your occipital artery, and over here, anterior cerebral artery, middle cerebral artery, right? Now you want to try identify the correctly matched. Okay, this, foot drop results due to fracture of the neck of fibula. Just wanted to put this image, right? Guys, now I just want you all to, so that we can start the quiz. Ready for the quiz? As we are told in the beginning of the session, okay, the toppers of the quiz, you have a reward awaiting for you. You can join for the quiz via the link shared in the chat box. You can put a thumbs up if you have enter the quiz. Put a thumbs up in the chat box if you have entered the quiz. Yes, Dr. Kanchan. Another few seconds, we'll wait for the others to join and then I'll start the quiz. Guys, do give your feedback, okay, to the Diginerv team. How did you find this session useful for you? Yes, we are more willing to do similar sessions before your NEET PG. If you find this useful. Shall we start? Yes, yes. Please send your feedback to the team, okay? So I'm going to start the quiz now. Guys, how much can you grade the session? Can you give your feedback for your 5, okay? Out of 5, how much score you can give for me for this session, right? Give it, enter it in the chat box also. Ma'am, Ratika ma'am.
Yes, ma'am.
Ma'am, the question, I'm waiting for the question to appear. Start, I've clicked the start.
Yes, ma'am. It will come.
Okay. Yeah. Guys, you can start answering it. And if you have constructive feedback also for the session, please let us know. That's very good. Dr. Madhumita, Sneha, Rabia, D, and Kartika. Good. We'll move to the next question. Question number 2. Did you get to see the question number 2? Ratika, ma'am?
Ma'am, please like press on the arrow. Then
Yeah,
they'll
I've
be
done it.
getting the. So this is going question number 2 now.
Do I have to press on that start one?
Yes, yes.
Okay.
Are you able to do that?
I'm not able to, ma'am. I don't get to see the quiz question.
Yeah. It will be coming.
This is the question number 2.
Yes, this is the question number 2.
So this is the Poppy's deformity, right? Involving the biceps brachii that inserts into the tendon inserts into the radial tuberosity. You have a best answer to choose, it will be the radius, right? Ma'am, I have pressed on that next option. So it's automatically loading the leaderboard result. Very good, Dr. Sneha, Dr. Raj, Dr. Dinesh, JSM, and Kamalesh. We'll move to the next question. Anatomical basis for this condition seen in carcinoma breast is due to infiltration of malignant cells into. Come on, it's an easy question. Retraction of nipple, pudgy orange appearance, right? Dimpling of skin, puckering appearance. Every time they ask about breast tissue, right? Retraction of nipple due to lactiferous duct. I think the leaderboard will come now and then we have to move on to the next question. Very good, Dr. Sneha, Dr. Raj, Dr. Kamalesh, Sneha, and Dr. Kumar. Good, 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 Dr. Infan. Question number 4. Fracture of the pointed structure. Okay, I'm not able to hear. Fracture of the neck of fibula. Fracture neck of fibula will cause what type of gait? Yes, you're right. Deep peroneal nerve injury. High stepping gait. We have discussed it, right? Excellent. Let's have a look into the leaderboard now. Yeah, Dr. Raj, good job. Dr. Kamalesh, Sneha and Kumar. We'll move to the next question. Yes. Which of the following label structure contribute to O'Donnell triad? We have done it right in our session. I'm sure 100% of you get it right. Let us see it. No one should make a mistake in this. Come on. Okay, good. Let's see the leaderboard now. Yes, toppers, congrats. Let's move on to the next question. Question number 6. Identify the market structure. I told you, right? Cross-sectional image in thorax, it keeps coming up again. This was again a repeat question from you. If you've gone through the previous year question paper, definitely you would have got it right. So the red arrows into the, yes, excellent. It's the pulmonary trunk. That's the right answer. Let's have a look into the leaderboard now. Yeah, that loading the result part, I think, is taking big time, consuming time. It is not the arch of aorta because in this section, you get to see the ascending aorta as well as the descending aorta. The market structure is the pulmonary trunk. Yes, Dr. Raj, Dr. Sneha, Dr. Monk, and yeah. Moving on to the 7th question. Which of the following act as a pelvic diaphragm is again a repeat question, a easy question that you cannot afford to make a mistake again. Easy. D is obturata internis. Excellent. C is the levator ani or the pelvic diaphragm, right? B is external anal sphincter and A is internal anal sphincter. This was asked just few years back, an easy question that you cannot afford to make a mistake. I'm sure if you get to see this image again, you will not make a mistake. Very good. Let's move on to the next question. Question number 8. The pointed structure is the, yes, internal pudendal artery. Which of the following is not a branch of the internal pudendal artery? The pointer has not come, I'm sorry. Which of the following is not a branch of the internal pudendal artery? Excellent. The vaginal artery is coming from the internal iliac, right? Again, in abdomen, the branches of artery is a frequently repeated topic, especially internal iliac artery, internal pudendal artery branches are very important. Inferior rectal artery, inferior rectal nerve, you can see it crossing the ischial fossa. Okay, vaginal artery is a branch coming from the internal iliac artery. Very good toppers. Dr. Raj, Dr. Kaushik, Dr. Neha, more. Very good. We'll move on to the next question. Question number 9. Identify the incorrect pair. Easy again. A, B, C, D. Can you appreciate A, B, C, D? Which one is that one glance you can pick out the wrong answer? I want 100% of you to get it right. We have discussed it. Not all the muscles are going to cause elevation, isn't it? D, the lateral pterygoid is going to cause depression. We have just learned it right now. Okay. Of the 4 muscles, the only depressor is lateral pterygoid. You should go for the best option. Let's see the leaderboard. I would really like to thank Radhika ma'am and the team for this entire session, coordinating it and for preparing this quiz and making it more interactive and useful for you people. Thank you, Radhika ma'am.
You're welcome. You're welcome.
Yes, doctor, very good. Let's move on to the question number 10. Yes, this was also previous year question, right? Identify this bone. Sometimes, yeah, what we think as easy, when you see it in the question paper, you get all the doubts in the world. Come on, 100% correct. It is the, yes. Come on. Yeah, it is the incus. Okay, it's not the malleus, it is the incus. Right, as I told you, anatomy questions, if you could make it right, na, your mark will shoot up like anything. And guys, have you all subscribed for the DigiNerve? Let's go to the leaderboard. Our DigiNerve app, right? It has like DigiNeet, where you have dealt like a quick revision of all the regions in the anatomy, previous year questions we have discussed. So if you have subscribed for it, like everything, it's going to be like very easy. Excellent, excellent, excellent. Can we move on to the next question? Question number 11. The third part of the vertebral artery is related to A, B, C, D. What bone is this? This is the atlas, right? A is referred to the posterior arch of the atlas. B is the foramen transversarium. C is the condyle that's going to receive the occipital bone to form the atlanto-occipital joint. D is the anterior arch of atlas. The third part of the vertebral artery we get to see in the suboccipital triangle and related to A, right? The second part of the vertebral artery only will be related to B. The third part is related to posterior arch of the atlas. Let's move on to the next question. Very good, doctor. Come on, the 12th question. True about the lesion of the structure shown in the histological image. So this is a histological, this is another very important topic in neuroanatomy. Cerebellum. I've given you 50% of the answer, right? Cerebellum histology, about the layers of the cerebellar cortex, about the Purkinje cells. There is again a repeat question. Lesion of the cerebellum is truncal ataxia. Resting tremor is seen in Parkinsonism, basal ganglia, right? Chorea, lesion of the caudate nucleus. Cerebellum is again a high yield topic, important image based question, cerebellar cortex. Moving on to the leaderboard. Leaderboard, leaderboard. Yes. One, Dr. Sneha, Dr. Kumar, Kaushik, Sandy, Raj, Monk, Infan, Bani, Kamlesh, Rabia, Dinesh, Kartika, very close. Yes, we'll move on to the next question. Injury to which of the pointed structure will lead to contralateral hemiplegia? A is mammillary body, B is crus cerebri, C is substantia nigra, and D is, yes, the tectum of midbrain. So injury to which of the pointed structures is going to lead to contralateral hemiplegia? Easy. Crus cerebri. Okay. D is the collicular region. Superior colliculus, inferior colliculus. Inferior colliculus related to the auditory pathway. Superior colliculus related to visual pathway, isn't it? Right. So if you learn the concepts, you can be able to apply it in the image. Identify the image. Let's see the leaderboard. Come on. Yeah, it's loading the result. Suppose. Okay. Question number 14. What is the level of the termination of the pointed structure in the given histological image? This is another high yield topic in histology. This is the transitional epithelium that lines the minor calyces, major calyces, pelvis of the kidney, ureter, urinary bladder, and the urethra, right? What is its level of termination in the male, right? Excellent. It is the prostatic. That prostatic urethra up to the colliculus semilaris, right? It's lined by transitional epithelium. Now let's see the leaderboard. The toppers. Very good. Very good. Very good. Very good. Very good. Leading Dr. Sneha, Dr. Kumar, Kaushik, Pant, Raj. Now let's move to the end of the quiz. The last test of the question. The last question for today's session. Yeah, this congenital anomaly is due to defect in. What is this congenital anomaly? Normally from the arch of the aorta, you get to see three branches. Now you see an extra branch that is going behind the esophagus, compressing the esophagus, leading to dysphagia lusoria. This is abnormal origin of the right subclavian artery. And yes, excellent, right fourth arch artery anomaly. So the toppers of today's quiz. Yes, guys, please enter in the chat box. Was this quiz useful, informative, interactive, interesting? Please put a thumbs up in the quiz chat box. And thanks to the team again. Let's see the results of the leaderboard. Thank you, Dr. Hari. Thank you, Dr. Umar Ranjini. Thank you, Dr. Sneha. Your feedback is a motivator. Come on, let's see the results of the leaderboard. I think it's taking time to load the results. So the toppers of today's quiz. Very good, Dr. Sneha. Hearty congrats, congrats, congrats.